Good morning, everybody. I see quite a few attendees filtering in now, which is great. Thank you so much. We're about to present the suicide prevention in primary care by Dr. Little. So thank you for joining us today, Dr. Little, and we're looking forward to your presentation.
Thank you. I appreciate the introduction, and I appreciate everyone spending some time this morning. We're going to spend the next hour talking about suicide prevention in primary care. So just letting people know that I'll be watching the chat and the Q&A. So if you have any questions or comments, feel free to put them in. We can stop and have a conversation. I can answer them as we go, or maybe we'll take some time at the end. So certainly feel free to do that as we go along. So we're going to be talking about very particularly primary care. And there is a large project that was funded by Centene in cooperation with ACU, which is the Association for Clinicians for the Underserved. If you have not heard of them, their website is clinicians.org. They're a national organization that represents frontline clinicians of all disciplines. So this project has been going on for a couple of years. Again, national project. We've had the opportunity to train over 3,000 primary care providers and their teams in 27 states. So it would be that, organizations, we were sort of seeking them out. Now it is word of mouth. We get lots of folks reaching out to us to do the training. And so if anyone there is in a healthcare organization, whether it's a primary care practice or a hospital-based system, and you want training for your primary care providers and the teams, then please let me know. You can certainly email me. I'll share my email at the end, and we can actually do the training. We do some in person, but a lot of times now we're obviously doing them by webinar. So the training actually came out of Zero Suicide, and I know you're very familiar with Zero Suicide. And part of the Zero Suicide faculty, I'd often be in the Zero Suicide Academies, which I love, and I know many of you are participating in. But what I really wanted to do was start to bring the idea of zero suicide and suicide safer care right to the front line, and to really make sure that we were doing something that would change what was happening in the primary care visit for people that were at risk for suicide. So there's a couple of things that we heard from primary care providers. So we heard that a lot of the traditional suicide prevention presentations and trainings that they had been to didn't really work for them. They didn't find them relatable. It didn't give them information that was translatable. We also know that many of them were not trained either in their current positions or in any of their training. But if they got sort of a traditional suicide prevention training, it just didn't feel like it was helpful for them. They felt a lot of time that in some of the traditional suicide prevention presentations that people didn't really understand primary care, and again, that it wasn't relevant to them. So I think that's a really important piece for people in suicide prevention to really understand that very particularly and very specifically for primary care, it really sort of needs to relate to primary care. So some of the things that we heard is more than 95% of the providers of all disciplines. So that's nurse practitioners, physician assistants, MDs, family practice, internal medicine, DOs said, hey, this is actually part of my role. And a lot of people were surprised by this. I was not surprised by it, having worked in primary care for so long. But a lot of people don't really think that as many primary care providers really think suicide prevention is part of their role. Again, most of them had not received any training, and there was no correlation between states that had higher suicide rates to mean that more providers were trained. One of the other pieces that I think was surprising to some and not surprising for me is that in the primary care practices, more than half of the behavioral health providers in these primary care settings did not feel comfortable or confident to care for someone at risk for suicide. And for any of you who have ever heard Richard McKeon speak, who really leads suicide prevention nationally, he has often said the only class he ever went to in his training was one that he taught on how to care for people at risk for suicide. So certainly this does not surprise me, but it's something to keep in mind. As we were going around and doing these trainings, many of the nursing teams and the behavioral health teams asked us to actually stay and maybe give them some additional training. So we definitely learned a lot as we were going around. There's a couple of very consistent things that we heard. And what we really tried to do and wound up doing was really modeling the training to follow a primary care visit. So one of the pieces is that oftentimes for primary care providers and practices, there isn't a lot of time blocked out to do a training, even if you're giving CMEs. Oftentimes, staff meetings are limited times. They often don't have where providers get together. And so one of the things we realized is that we were going to have to do the training in a short period of time. So the training that we actually do wound up being an hour. And that's because an hour is the time for rounds, an hour is the time for a lot of staff meetings. And so the trainings wound up, even started out longer, but wound up being an hour. And that you really need to be able to compare what's happening in primary care with what needs to happen around suicide safer care. So just sort of to give some examples and some things that resonated with primary care practices, as an example, was that oftentimes we heard, I don't have the knowledge to assess or intervene. So in other words, I don't know what to do when someone tells me that they're thinking about suicide. And we came up with the idea and have since been training people, and practices have said that it's been very helpful, is this concept of storage statements and practicing in the training. So if someone comes in and they tell you that they're thinking about suicide, and maybe it's the first time that they've told someone, in 3 sentences, what would you like to convey to them? So first we brainstorm about, what do we want someone to know who just told us that they're thinking about suicide? So that we heard you, thank you for telling me you're thinking about suicide, that you're important, right? Thank you for telling me you're thinking about suicide. You really matter to us here at the practice. Your life is very important to me. And then maybe that I have hope for you, right? To give someone hope. And we actually practice the storage statements. We give them 2 or 3 sentences, very specific language, ask them to then think of some storage statements of their own. And I've had primary care providers come back to me and say, hey, at the time, I kind of didn't take that storage statement thing seriously. But then a couple of days later, I had a situation, and boy, was I glad I remembered your storage statements. So we found that the storage statements are incredibly helpful, and we really try to define them. And providers like having, and the teams like having, that very specific language. The other piece that we heard a lot was, we don't have a lot of time. And having worked in primary care my whole career, I will say that that is certainly true. 8 to 15 minutes for a primary care visit. It's really difficult. There's lots going on. And really thinking about how you can convey what needs to happen in terms of suicide safer care, and comparing it to other current workflows. So for those of you who have heard me talk before, I give actually a very real example, but encourage people to come up with similar examples, is that I often will talk about how I brought my husband into the primary care visit for some hearing loss. And they took his height and his weight and his blood pressure, and then the medical assistant left the room. And a little bit later, the primary care provider came in and she took his blood pressure. And I'm kind of watching this and I'm getting a little bit concerned. And she said to him, listen, your pressure's incredibly high. I don't think you're going to be able to go home today. And she asked him some questions and she got some information, talked to him about what was going on, asked him about medications, and then said, hey, listen, I'm going to go finish up with my other patients, and then I'm going to come back and we're going to talk a little bit more. And so whether or not his pressure was high or he said yes to suicide, the same things happen. So really making those comparisons, right? Getting the information, putting information in, putting a plan in place, understanding an appropriate level of care, Those things happen every day, all day in primary care, and really making those comparisons. So someone that comes in that is experiencing asthma, they might come in, they would get a treatment, we would talk to them, we would find out, hey, what about emotional triggers, about triggers that might be where they're living, around carpet or different environmental triggers. We would ask them about medications. Had they been to the emergency room? Had they been using their rescue inhaler? We would talk to them a little bit about maybe education. Do they need help using their inhaler or a spacer? We would do an asthma action plan. If needed, we might make a referral to a specialist, maybe to go out to the home to help them with their, what's going on in the apartment or in the home. And maybe we would refer them to a pulmonologist or schedule them to come back in a week. So that is a very traditional and standard response to somebody coming in with asthma. And it would exactly mirror what might happen if somebody came in and said, yes, they were thinking about suicide. And so really making those comparisons for primary care providers was incredibly helpful, because it really helped them say, wait a minute, you know what, I actually do this. And I would remind them that, yeah, we shift gears all day long in primary care. Like, it would be a beautiful day in primary care if somebody came in and they just had one thing going on, and it was the actual thing that was the most urgent. And so making those comparisons was incredibly important. So one of the things that we would really encourage is to be really familiar with primary care providers in the workflows and understand what's important to them, and really understand what their current workflows are and be able to speak primary care. If you're going to engage primary care providers in this work, you have to speak primary care and understand that there's some varying levels of comfort, right? And what does that look like? So for example, when we were talking to some of the pediatric providers, they were like very concerned. They're like, adolescents, they're very impulsive. I'm really concerned. And we really had to talk very specifically about caring for adolescents. What we have found and gone to a lot of residency programs is that the residents and the trainees were really receptive to doing this work. They had received some additional training, they were on board, they really wanted additional information. And we saw very clear differences between some of the preceptors and some of the residents. The other thing, sadly, is that we did not go to a residency program anywhere in the country where a resident didn't come up to us and tell a story about someone that they had lost to suicide, either in medical school or residency. And so that was very touching to us. And when we think about physician suicide, we know that we lose a physician each day to suicide. So certainly very concerning. But again, residents and trainees were way more receptive. I would also say it's important doing this work to understand the electronic health records. How can the electronic health record help with suicide safer care? How can your system help you do this work? And I know for some of you doing the zero suicide work, I've heard that the electronic health records have been a tremendous barrier. And so I would always say, don't let perfection stand in the way of progress, that there are things that you're able to do without these really complicated builds. Those can be something down the road versus a what's in there for now. I know that at some points when I was doing this work, I used to actually put Columbia scales in as a procedure so that I would be able to track when they happened. I would put safety plans in as letters so that we could modify them and attach them to visits because they weren't built in separately. And so there's always ways that you can figure these things out, but you really have to have an understanding of the electronic health records and the role that they play in order to really work with the primary care providers. I think it's also really important for everyone to understand why primary care is so important and the numbers of people who died by suicide who saw their primary care provider in the month of death. And I think some of the newer pieces for me is that when you look at some of the newer studies, they're talking about patients who are not engaged in care at all actually resurfaced into primary care during the month of death. and an increase in portal use. I have a friend that works for the VA, and I was talking to her one time about how we were really figuring out incorporating safety plans in electronic health portals and patient portals into safety plans. And one of the things that she said, and I went back and looked at it as well, is that there was an increase in portal usage in the month of death. And so I think that's something to really bring up and for people to be aware of, because I'm not sure that it always gets the attention. And I think it's important to share information. I know that you're talking a lot, certainly about the crisis around youth suicide, but I always try to share the information with primary care providers, particularly the pediatric providers, because I don't think they really understand yet how much of a problem it is and how many youth are actually impacted by suicidal thoughts and attempts. I also always try to bring in regulatory. And so the Joint Commission, CARF, the others are really saying, hey, you have to put a process in place around caring for people at risk for suicide. So what regulatory body do you have so that you can pull some information up and make sure that you're tying it in to some of their regulatory requirements? So for those of you who have done anything around zero suicide are incredibly familiar with this Swiss cheese slide and people falling through the cracks. There's some very specific examples that we can give to primary care providers and practices. And so one of the things or examples that I often like to give is that many times people at the front desk who are answering calls into the practice don't know that someone's at risk for suicide. And that's a really important place where people can fall through the cracks. So I often give an example of a practice where somebody called and she canceled the primary care appointment, she canceled the mental health appointment, canceled a WIC appointment, died by suicide, and nobody who answered the phone knew that she was at risk for suicide to do anything different. And there was no process in place to catch that she had canceled three appointments within a very close time frame. Also, it will come up around billing and billing teams, and that people may make suicidal statements when they're talking to billing personnel. So what do they do? There was a practice, actually, I was out west recently doing a training for primary care organizations. And one of the practices told the story about how someone had died by suicide, and it just sort of came up in a conversation in a staff meeting that they were letting people in the practice know. And there was someone from billing who said, I actually spoke to that person last week and they said something, and I thought it was kind of difficult at the time. And she said, and now I feel really badly because I didn't know to do something. And so, this person had made a suicidal statement during that phone call. And so there's all kinds of places in primary care practices where people can fall through the cracks. And those are just some examples. So oftentimes I try to get primary care providers and practices thinking about some scenarios like that they might be able to sort of wrap what I always like to say is sort of a warm, fuzzy blanket around people who are at risk. I think it's important, and I always mention during the trainings for primary care providers, the components of zero suicide, because even though we're talking about what can happen during a specific primary care visit, I do want them to think systemically or to try to adopt all of the core components of zero suicide into their organizations or into their practices. I also think it's really important to reinforce the systemic approaches. So one of the reasons that we trained primary care providers and their teams so that everyone could be engaged in the process, everyone could get the information, and that you could really try to engage the nursing, the billing, the front desk staff, and talk to everyone about how do they engage people at risk, how do they care for people at risk, and how can they fold it into some current system. So oftentimes I would ask, well, what do you do now in terms of peer chart review? And so if you were doing a peer chart review and you had a patient at risk for suicide, What could you look at? What would you want to see in that chart to make it a part of their compliance training? So one of the things we learned training primary care organizations is that it was often not as helpful to train people in the beginning, when they first started the organization, because in an organization, you have two populations of people, right? Those are there now and those that are coming as new employees. That we actually found it better to wait a little bit because, when someone comes into an organization, they get that first day HR training, which, the best thing that can happen is you get a good lunch, right? But then you might get some EMR training. And so what would happen is that we actually found it a best practice to wait a little bit, 2 or 3 weeks, and then train people on suicide safer care and the electronic health record at the same time around suicide safer care. So here's what a safety plan is. Here's how you do one, and here's how you document it. And people thought that that was much better, that they could put it in context then, and they weren't sort of overwhelmed with, starting a new organization and having to learn everything about a new organization. So that emerged as some best practices in terms of trying to train providers around suicide safer care or practices and staff. So there's a couple of things that to think about and tie it into depression care screening. So organizations, primary care organizations, are really required to screen people for depression. The cadence at which they do it varies, but it's important to know that for federally qualified health centers, rural health centers, that information gets reported to HRSA, to the feds, right? Sort of their overseers. Many of the payers request that information. So primary care practices that are in the New York State Collaborative Care Medicaid program have to report their depression screening rates. They have some quality measures around depression screening. FQHCs, as an example, have to report on patients who are getting subclinical scores. It's built into the electronic health record. Many organizations have depression care registries. And so a lot of the conversations you're going to have around training primary care providers jumps off of and ties into what they're doing around depression screening, how many people they screen, what they do around screening. Do they hand people forms? Do they do it in the computer? How do they track? Do they have a registry? And so oftentimes it's really helpful to know what they're doing around depression screening before you actually do the training. Most organizations, in primary care are going to be using the PHQ. I put this up because I still have people in trainings who are not familiar with the PHQ. It would be really hard to train primary care practices and not be familiar with the PHQ. And many of them certainly have a process in place for question 9, thoughts you would be better off dead or hurting yourself in some way. So what I really like to do, and primary care practices have found helpful, is I actually like to role model for them exactly what they would do when they have somebody answer yes to question 9. And so I will tell them, whether it's on the computer or whether you're doing it on paper, pull it up and say, okay, so I see you're having a lot of difficulty sleeping, and that's more than half of the days. And I see that you're feeling tired and not having a lot of energy, and that's several days. And I can also see that you're having some trouble concentrating, like on the newspaper or TV, and that's a problem for you more than half of the days. So those are probably related, and I can see that you're really having a difficult time, and I definitely want to talk to you about the trouble that you have, sleeping and concentrating. I also see that you're having thoughts that you would be better off dead or hurting yourself in some way, and that's more than half of the days. So thank you for telling me that you're thinking about suicide. I'd like to start and talk to you about your thoughts of suicide, so that essentially you're really role modeling for people. This is how I talk to someone about the PHQ-9. This is how I launch into the discussion that you told me that you're thinking about suicide, so that I can say, thank you for telling me you're thinking about suicide. And I can use my storage statements so that I'm going through the PHQ-9. I'm acknowledging number 9, I'm using my storage statements, and then I'm saying, listen, I want to start there, right? And ask you some additional questions. And primary care providers have said this was incredibly helpful because they didn't really know how to start the discussion. And so part of their workflow already is really to review the PHQ-9 with people or to go over what they said. And so it's really helpful. And I literally will take it out and I will role model it so that they can see what happens and then say, okay, use your storage statements. And what that does now is sort of take them through the primary care visit in the order that things might happen. Many organizations will still use the PHQ-2. To be honest, when people ask me in primary care trainings, I tell them, you know what, at this point, a lot of organizations are just using the PHQ-9 for a couple of reasons. One is because we want to actually ask people about suicide, and also because the other information is incredibly helpful as well. And then we want to make sure that if they're positive, we're doing something around suicide risk screening. So a lot of organizations now, primary care, are putting the ASQ on the bottom of the PHQ, and they find that incredibly helpful. And you're starting to see a little bit in electronic health records, those pieces tied together, but certainly really helpful. And I also want to remind people that this really doesn't take a lot of time. It takes as much time. I have done suicide safety plans, asthma action plans, and some of those pieces, they all take the same time. This doesn't take a lot of time. And so you really want to make sure that as you're going through it, say, hey, I just went through that PHQ-9. It didn't take me long at all. And that's one of the reasons to really role model it. The other thing that often comes up in primary care trainings, and this I encourage all of the time. And so one of the things that is really a driver in primary care is the problem list. While some providers are better than others at really updating it, the problem list is really a central place. And it's so important to put the suicide risk on the problem list. So one of the things that I always reinforce in primary care trainings is that, hey, the ICD-10 codes for suicide risk, the R code as an example, is already in your electronic health record. You don't have to add anything. You don't have to do anything. It is already there. The other thing that we found is that most primary care providers, I always like to do a little survey and I always ask, so tell me, how many patients do you have that have diabetes? And they tell me, oh, we have this many people and they're controlled and we have this registry, and they give me this whole explanation. And then I ask, so how many people do you have at risk for suicide? And literally crickets. I would say across the country, there have been less than a handful of organizations who have really been able to answer that. And so one of the benefits of putting suicide risk on the problem list is that it automatically gives you a way to have structured data. And so one of the things that is really helpful is it's there, it's available to everyone, so that if I'm covering, right, if I'm a covering provider for you, then that's important information for me to have. I may make different decisions knowing that you're at risk for suicide. I will oftentimes have people tell me in trainings, and surprisingly, mostly behavioral health providers, but they will tell me in trainings, patients are not going to want suicide risk on the problem list. And so I try to give people very specific language. Thank you for telling me that you're thinking about suicide. I just want to let you know that I put in the chart that you're thinking about suicide because you really matter to me. And I want to make sure that every time I see you or talk to you, or every time someone on my team sees you or talks to you, we make sure you're safe. And so I've never had anyone give any concerns about that language. And I always give very specific language that people can use to talk to patients about putting suicide risk on their problem list. And again, role play it. The other thing is that on the problem list, you have the ability to resolve something. And what that means is that it will stay on the problem list even though it's not active. So if someone isn't actively at risk or on a pathway, it's there historically and it's available and it can influence care, and it has the ability then to list a lethal mean, to have some additional information there. So I always tell people, if you do nothing, go back and start putting suicide risk on your problem list right away. And oftentimes I've heard from providers that they've started to do that, and it's actually made a big difference. And it also means that now they can run a report on the patients that they have who are at risk for suicide. The other piece that I always try to reinforce in training is to think about two populations. So oftentimes when we train primary care providers or others, we really focus on what you do when you identify someone. And I think that's super important, and we definitely want to have a process in place to be able to do that. But oftentimes we forget about what happens when this patient comes back for primary care. So a couple of things to think about is that if we don't put it on the problem list, as an example, we may miss somebody coming back for care. I often tell a story about a chart that I reviewed one time in a school-based health center, and an adolescent came in and he needed forms filled out for sports. And he came in, he answered, screened positive for thoughts about suicide. There was lots of commotion. I think that they sent him out. And he came back 3 weeks later, saw a different provider to get his forms filled out, literally came in, had his forms filled out and left. Nobody asked him about suicide. Nobody asked him if he was safe. Nobody asked him if he was in care. It was as if it never happened. So imagine the message that we sent to that adolescent, firstly. And secondly, if you can imagine telling your primary care provider something really important, and then the next time you came in, nobody even remembered. And so really important to think about two different populations. When if someone has diabetes and they go into primary care, there's very specific things that they do. They might check your sugar. They would ask you about your medications, right? Very specific things. And so what is the expectation in the primary care organization for patients that are coming back for care that are at risk for suicide? I had this really great idea one time, turns out not to be a great idea, but that I would have the banner turn red on the electronic health record system for patients who were at risk for suicide. And what I found out is that it didn't actually change provider behavior at all. And that was really on me, because I had never really explained what the expectation was if someone came back who was at risk for suicide. And so I really try to talk to primary care providers and practices about, what do you expect to happen? Maybe it's that we ask patients, do you have a copy of your safety plan? Has anything changed on your safety plan? Maybe we ask them a couple of questions from the Columbia scale, but that we're really clear for them, with them, to think about these two very separate and distinct populations. And I always refer them back to Zero Suicide to take any access to lethal means trainings or some of the others if they want, because a lot of times they find that helpful. So I bring it back in just to help them think systemically, and also to give them some information and resources on training. I also encourage organizations to do pathways, and pathways are very different than workflows. Workflows are kind of like a little bit about who does what and when. Pathways are more about how do we care for people at risk for suicide. And I like to start sometimes when I'm working with organizations and say, if we were going to do an excellent job caring of people at risk for suicide, what would we do? How would we care for them? And then using that to build a pathway in an organization. And so oftentimes you'll hear organizations say pathway. So really wanting to know what their process is or has been for caring for people at risk for suicide. Do they have a pathway, for an example? So the other piece that we always want to talk to organizations about is an appropriate level of care. And oftentimes giving them some ability to relate it to another primary care condition. So for example, everybody that comes in with chest pains, we ask them some questions. We would probably do an EKG. Not everybody would go to the emergency room. Not everybody who comes in, or asthmatic that came in before, didn't go to the emergency room. So one of our jobs in primary care is to make sure that people get the appropriate level of care and making those comparisons. So if everybody who had an asthma attack got sent to the emergency room, what would happen? First of all, our friends in the emergency room would not be happy. Second of all, they wouldn't be getting great care, right? Because they would just be going to the emergency room. Some patients would say, well, why do I need to go into the office? I may as well just go right to the emergency room. Or they would say, I don't want to go to the emergency room. I don't need to go to the emergency room, so I'm just going to stay home. And then we're going to have people who are staying home who are at risk for suicide or having asthma or chest pains. And that's certainly what we want, not what we want. And so again, making those comparisons and providing very concrete information about what responses are for people who are at risk. So oftentimes people will say, well, we can't do that, in primary care, we can't assess risk. But what I want to do is continually take them through the primary care visit. Now you've screened someone for depression, as an example, you know how to go through your PHQ. You've got storage statements that you can use if someone answers yes to question 9 or tells you that they're thinking about suicide. And so we often will train and use the Columbia scale. And it's really helpful to have it color coded. And I will often, even though this is sort of officially called the Columbia scale short version, I actually call it the primary care version for no reason than it makes people feel special in primary care. But what is really helpful is that it is color coded, and so that you can help them with different workflows based on sort of where people screen. And one of the things that we often do is give people very concrete things to do for patients who are yellow and orange, and talk to them very specifically about what they can do and should do in the context of a primary care visit. And continuing to take them through that primary care workflow. So now you've answered yes to the PHQ-9 or the depression screening. I've used my storage statement, and then I'd say, I'd like to start and talk about your risk for suicide first. I have a couple of questions that I'd like to ask, and then go into the Columbia scale, so that it gives them a way to transition through the visit to really get the information and make the decisions that they need to. And so we will tell them about the Lifeline. We all know how effective the Lifeline is, right? I'm certainly preaching to a converted audience, but what I actually do is I have them literally pull out their phones, and I will stop and make sure that everybody in the room pulls out their phone, and I have them program the Lifeline in, and I have them send a text. And what I talk to them about is the ability then to say to a patient, pull out your phone, let's put the Lifeline in your phone. So I'm not going to give you a little index card. I'm not going to give you information. We're literally going to put this in your phone. And then maybe you can give them a call and I can go see another patient and come back, or you can send a text so that you know what happens, right? And that you're giving them something very concrete to do. I also give them the Now Matters Now website. It is incredibly helpful to be able to have people pull it on their phones. I have some practices who say, you know what, we put someone on an office computer and we have them go to the website. People find it really helpful. And so now for those patients who are in the yellow or orange category, we've given them two really helpful things that they can take with them. And so providers and practices really love the idea of having very concrete resources and things to do. So they find this incredibly helpful. And what most of them have reported back is, actually we have adopted this. I also give them the Suicide is Different website, mostly because they have people that come with them to the primary care practice, or they're, have parents or guardians, and people find it helpful. So giving them some very specific things that they can do. I also talk to them about the emergency safety plan. And we do it for a couple of reasons. And that's because a lot of times in primary care, the idea of doing a safety plan with someone, who may be yellow on the Columbia scale, as an example, oftentimes there isn't the time or the resources maybe to be able to do it. And providers want something very specific that they can give to patients. So oftentimes we'll talk about using the emergency safety plan and making it very concrete for people. So, hey, when you were young, you were taught if you caught on physical fire to stop, drop, and roll. Even though the likelihood that you might catch on physical fire is pretty low. So I want you to know what to do if you catch on emotional fire, even though the likelihood that you might catch on emotional fire is not high. And you can do some of the same things. You can stop, drop, and roll. I don't want you to make any decisions. You can put cold water on your face, so that you go through this emergency safety plan and you sort of role play some of the language with the providers in the practice. They really like it. I've heard from many of them that they have printed it off the Now Matters Now website and actually give this information out to people sort of across the board, so that people have it, which I think is a really nice thing to do, and gives people some very solid and concrete information. It also gives them the ability to talk to patients and to start some of the conversation around safety planning and some of the things that are going to be able to keep them safe. I will also encourage them at times to go to the Now Matters Now website so that they can get familiar with some of the stories and be able to do some of the clinician trainings on there. So there's a really nice scenario from primary care and some of the other pieces. So I had a question in here. I'm just going to stop and take. Would it be better to have an alert in the patient record on suicide risk instead of adding it to the problem list? So I think there's a couple of things that to think about. So one of the things that we want to try to do is to know our population of patients at risk for suicide. So the problem list is structured data, whereas a lot of the flags are not, so that you're not able to know what a flag is for. The other piece is that sometimes flags are limited in terms of who can see them. The other piece is that sometimes flags are, I don't want to say ignored, but maybe missed, particularly if a patient has quite a few flags. And so I think it really depends on the system. But one of the things we know is that oftentimes the having it on the problem list means that it's really visible to providers so that they can address during a visit. And if somebody's on call, then it's very specific information that we can see. So there's some conversation about the Columbia scale instead of the ASQ. Honestly, they're both great tools. A lot of the issue comes down sometimes to what's in the electronic health records. The ASQ, and I love the ASQ, certainly. I am a fan of both tools, but it is not in as many or electronic health records. And so oftentimes you're talking about the Columbia because that's what's built into the electronic health record. I have a lot of practices that will use the ASQ for their pediatric population. And for those of you who can't find the color-coded Columbia scale, we can certainly make sure we get that out to you, because when you're doing these trainings, it's really helpful to say yellow, do this, orange, do this, red, do this. And it really gives a little bit of a baseline and a framework. And one of the things that's important in doing this training is this caring for people at risk for suicide has been very scary, and providers have done very different things based on their level of training and comfort. And what you're saying is, listen, you're going to care for people who are at risk for suicide. Here's how you might know who they are. Here's how you respond. Here's some things you can do, and be very specific. So if people can't find that color-coded Columbia scale, then we can make sure that we get that out to you. So we can absolutely do that. So thank you for those questions. But again, the Columbia scale is really helpful. This emergency safety plan is really helpful. And the conversation about, physical being physically on fire and emotionally on fire is a really clear and concrete way for providers to start to have a conversation about safety planning. So I think we all know, or should know, that doing a safety plan really takes a lot of time, right? If I'm going to sit down and do a very personalized safety plan with someone, it takes some time. So many primary care practices are not necessarily set up to be able to do, some comprehensive safety planning. And so what we want to try to do is we want to try to have them understand the idea of safety planning and why it's so important. We want to make sure that they know that we should not be contracting for safety anymore. We want to make sure that we're talking to them about some very specific things that they might be able to do. So how do I get information about things that might be helpful for me to do? And one of the things that I try to tell them is, you want to make sure, as sort of a quick and easy way, is any activities are doable at all times of the day and all times of the year. And if they're not, so if someone maybe wants to go outside, as an example, for a walk and walk in the fields behind their home, then that's maybe not something that's really doable in the middle of January or a storm or in the middle of the night. So what's plan B? Maybe that they use Now Matters Now or the Lifeline. And so really giving them some very quick tips like that to be able to be helpful for them to do some very basic safety planning with people who are in the office and may potentially be at risk. So I want to flip back to this for 1 second. The other thing that I wanted to just realized I left a section. The other thing that I really like to talk about when we're doing some of the safety plan training is that to try to also correct some of the language as we're going along. So I will often start and really level set with primary care practices. You've heard me say die by suicide. I often, versus commit suicide, I will often talk about some language that I will see in primary care charts. I still see a lot in primary care charts, patient was manipulative or patient was attention seeking. And so I really try to talk about using that language in charts and give them a different language. So what did the patient say? Or what did the patient do? That's inherently going to be more helpful to your team. I also talk to the primary care practices about caring contacts. And oftentimes, you want to try to not come off as you're giving them, some additional things, but it is helpful for them to understand caring contacts and give them a place where they might be able to do it. So for example, if someone comes into your practice, they talk about being at risk for suicide, and you can send them a little note that says, hey, it was really great to see you today. I hope this note finds you well. I'm looking forward to your appointment next week. And making sure that they understand not to tie it to something like a missed appointment. So I do spend a little bit of time on caring contacts. But the most important thing is to be able to go through and follow a primary care appointment from beginning to end and talk to people. So if someone scores red, those are the people who may need an alternate level of care, who need a set of behavioral health eyes if you have them in your practice. And so, those are often really helpful tips for people. So I want to just try to take, there's been a couple questions in the chat. And also, there's two questions that were sent to me. So some worry about asking about suicide because of liability. I would have to say, in training primary care providers, the liability question doesn't come up as often as you might think. That doesn't mean it never comes up, but it doesn't come up as often as you would think. And one of the things that we try to say is, listen, we know that sending people to an inappropriate level of care is not good for them. So we don't want to do it for suicide, for asthma, for any presenting problem. But also, one of the best things that you can do around liability is have a very consistent process, have a pathway, use evidence-based practices like, safety planning and tools like the ASQ and the Columbia scale that you use every single time. Have it on the problem list so that you make sure it's addressed in every visit like you do with other chronic illnesses. And if you have a process in place and you really follow it each time with these best practices, then that's really what's going to be most helpful for you around your liability. And so we make that safety plan template available. It is actually the Stanley and Brown safety plan. It is one of the ones that everybody should be using. It is one of the ones that is built or starting to be built in a lot of the electronic health records. You can Google it. It is also on the Zero Suicide website as well, and you can find it. It is actually a really nice tool to have, and certainly one of the ones that's supported in the field. The other, the ASQ, if you go on the NIMH website for the ASQ, what's nice about that little packet of information is it has some scripts for nursing and also for parents and guardians, which practices find helpful, because often primary care practices will say, what do we tell our nursing team to say if someone calls into the practice who might be thinking about suicide? The other question that got sent to me here in the chat was, what do primary care, how often are visits? So one of the things that we usually tell primary care providers is to have someone come back, maybe your yellow patients in 14 days, the week after next, and maybe your patients who are, orange, be able to go in and maybe do 7 days so that they come back in 7 days. And that's incredibly helpful for people as well. So I would say that that's probably the best way to be able to do that. Someone has actually asked about the training again. So I'm going to put my email in the chat. And if you have an organization that has primary care providers and teams of folks that you think would benefit from the training, then we would be more than happy to do it. You can email me and I can connect you. A lot of times you get me, to be honest, but there are some other folks who do it. So it would depend on that, but we'd be certainly glad to do that. So I know that we are coming up on time. So I want to make sure that we're ending on time and being mindful of other speakers. My email is here again, in addition to the chat. And I just want to reiterate, when you're thinking about training primary care providers, so if you're an organization and you're rolling out Zero Suicide and you have primary care providers or primary care practices, really think about the training. It should look much different than other trainings that you might be doing, and really try to take people through the course of the primary care visit and piggyback on what they're already doing and say, hey, you already do this. Somebody comes in, their sugar is 400. That's what the visit comes about. And you have a whole process that you do. So just follow those same practices and those same workflows. So I know that I'm at time. I really appreciate everybody's time today and talking about primary care and suicide safer care. So as many of you can tell, I could probably talk about this all day, but I will turn it back over to my new friend, Greg here from the state, to bring us home.
Thank you so much, Dr. Little. We really appreciate your presentation, and thank you all for your thoughtful questions for Dr. Little. We have about 5 minutes before our next presentation. It'll start at noon. which is a zero suicide story by Waukesha McKinney. So we hope everyone will transition over to that presentation. Just one more quick thing. This presentation was recorded. It will be available on our aim40.vfairs.com event website, and then eventually it will be uploaded to our SPCNY website as well, so we can rewatch this. Thank you again so much, Dr. Little. We really appreciate it.
Thank you, everyone. Have a wonderful day and enjoy all of the presentations today.
Thank you.